good evening, everyone. Today is going to be a delicate talk about a neglected disease in neurology, which is ALS. ALS, not very uncommon disease, approximately it's 1 in 100,000 globally, and I believe it's the same rate in GCC areas. We're going to have two different topics today about ALS. The first talk would be held by Dr. Mahmoud Al-Haji, who's a great colleague of us. He is consultant neurologist and neuromuscular specialist who had his fellowship in Ottawa, Canada. He works as a consultant in Al Musa Specialist Hospital in Kingdom of Saudi Arabia. His talk today will be done on updates and diagnostic criteria of ALS. Dr. Mahmoud, the phone is yours.
Thank you, Dr. Abu Madani, for giving the opportunity to talk about update on ALS electrodiagnostic criteria, no financial disclosure. So I will start with a case. I saw this patient like 3 weeks ago. He saw like 2 to 3 neurologists before me, one EMGer before me. 2 of them work in a tertiary care center. He's a 52-year-old male patient who presented with 8-month history of swallowing difficulty, slurring of speech, and weight loss. He also endorses dysphagia to both solid and liquid and choking on swallowing. He has lost about 20 kilograms over the past 8 months. He also reports shortness of breath on exertion and generalized body weakness. His family have noticed that he seems to cry easily, but there were no episodes of easy laughter. There is no history of diplopia or incontinence. Past history is remarkable for renal transplant 20 years ago and parathyroidectomy secondary to adenoma. He's currently on cyclosporin, prednisolone, azathioprine, and aspirin for his renal transplant. Social history, he's married with children and he's a heavy smoker. On neurological examination, he has spastic speech. He has neck flexor weakness. It is like the neck flexor is 3 out of 5. The extraocular movements are normal. The tongue is atrophied with occasional facets. The jaw reflex is hyperactive. I have also noted an AV fistula on the left arm. There is a florid fasciculations everywhere, like in the upper limbs, in the paraspinal muscles, and in the lower extremity as well on both sides. I couldn't appreciate any spasticity when I examined for tone. The power, motor power, he has, symmetrical, proximal and distal weakness, grade 3 to 4, proximally and distally. He has diffuse symmetrical hyperreflexia with cross-adductor response. Plantar response is flexor bilaterally, and tertiary exam is normal. So I have 2 questions for the audience. The first question is, what is the impression? And the second question is, do we need any investigation to secure our diagnosis, and why? I don't expect any answer right now. I'll give you time to think about it, and we'll come back to the case later on. So basically, ALS is a progressive motor neuron disease with a mixture of upper and lower motor neuron findings. Diagnosis is made upon meeting clinical criteria with supportive EMG findings. Basically, ALS is a clinical diagnosis. I cannot stress this point enough. EMG is meant to be an extension to our clinical assessment. So the main thing here in the diagnosis is a, a clinical scenario or a clinical context, and the EMG is supportive for our clinical, impression. And of course, we need to roll out the mimickers. Workup for ALS may include CNS imaging, EMG, appropriate serum CSF studies, uh, case by case. And the role of nerve conduction studies and needle EMG remain the most important diagnostic testing for ALS, but it is an extension for the our clinical impression. Nerve conductions are used primarily to help, roll out mimickers like MMN or multifocal motor neuropathy with conduction block. And the latter, the needle EMG, is to establish evidence for widespread active denervation and chronic reinnervation. Early diagnosis lead to earlier initiation of appropriate disease-modifying therapy and supportive care and possibly enrollment in clinical trials. So, as I have mentioned, that the fundamental quality of ALS is the presence of both upper motor and lower motor findings that spread without remission to ultimately involve multiple body segments, namely craniopalpar, cervical, thoracic, and lumbosacral, often in a predictable pattern. I mean, upper motor neuron findings can be established from practical point of view by clinical examination. So we should look for spasticity, hyperreflexia, Babinski sign, Hoffman sign, and pseudobulbar affect. Uh, on the other hand, the lower motor neuron findings can be established either by clinical examination or needle EMG. The clinical features of lower motor neuron lesion include, as you know, flaccid weakness, atrophy, hyperreflexia, muscle cramp, and fasciculations. The electrodiagnostic criteria of lower motor neuron findings or axonal loss is to verify denervation in a weak muscle and chronic reinnervation. As I have mentioned that ALS is mainly a clinical diagnosis, so I'm reviewing here the most common presenting features of ALS. Dysarthria is the most common presenting symptom in ALS, 32% of patients. Hand weakness in almost 20% of patients. Proximal upper limb weakness in almost 14% of patients. Foot drop in 12.5%. Fasciculation cramps in 11%. Exercise intolerance infrequent only in 4%. Respiratory failure in 4%, cognitive impairment in only 2%. So the feature in favor of ALS is, the recognized feature of ALS is the progression over time, and in space from one segment to the next, or within the same segment. This, picture illustrates very nicely the split hand syndrome. So in split hand syndrome, there is like disproportionate involvement of the lateral side of the hand when compared to the medial side muscles. As we can see here, the FDI and ulnar innervated muscle and abductor pollicis brevis and median innervated muscle, both are supplied by the same root, CAT1, are disproportionately involved or affected and atrophied when compared to the medial hand muscles namely ADM, which is ulnar innervated supplied by the same route, CAT1. So motor neuron disease is thought of as a syndrome with a phenotypic spectrum ranging from pure upper motor neuron phenotype like primary lateral sclerosis to pure lower motor neuron phenotype like SMA and PMA, progressive muscular atrophy, to a phenotype with mixed features of upper and lower motor neurons, namely ALS. ALS can be sporadic or hereditary. So, what are the features that argue against ALS? The lack of disease progression is the most common reason for diagnostic reconsideration. Patients who never develop bulbar symptoms despite long follow-up may prompt a reconsideration. Early bladder and bowel dysfunction. Pain is generally quite unusual in early stages. Prominent sensory symptoms, although like around 6 to 30% of ALS patients have sensory symptoms, but usually mild and only subjective. So the nerve conduction studies are mostly normal in terms of from the sensory point of view. Ophthalmology also argue against ALS, dementia, and extrapyramidal symptoms also argue against ALS. Symmetrical findings also argue against ALS. If the patient present after 2 years from symptoms onset, this will be unlikely in patients with ALS. This is like a laundry list for ALS, mimics, and differential diagnosis. I'll not go over it. The most common ALS, differential diagnosis is cervical spondylosis in most common cohorts, and this is the most common in most cohorts. MMN, multifocal motor neuropathy in the Ireland cohort. Kennedy disease is another common ALS differential diagnosis, and peripheral neuropathy. So, as Dr. Abu Bakr has alluded to, that ALS diagnosis, ALS is a forgotten disease. ALS diagnosis is usually delayed like by 10 to 16 months from symptoms onsets. The patient may see like 3 to 4 doctors before seeing a neurologist. The patient see 3 to 6 doctors before ALS diagnosis is made. Referral to a neurologist was not consistently found to reduce diagnostic delays, just like our patient. Bulbar onset of ALS was noted to significantly reduce the time to diagnosis. So what are the factors contributing to delay in ALS diagnosis? Symptoms onset to the time patient present for evaluation. This is the most important factor in delaying the diagnosis. A wrong referral. The patient may be referred to ENT or ortho or a neurosurgeon. For example, a patient with a foot drop who presented or who is referred to a neurosurgeon, the patient might undergo unnecessary testing like lumbar spine, and they will find an L4, L5 disc, and they will do then unnecessary procedure like a surgery in the hope of improving patient symptoms. This all will contribute to the delay in the diagnosis of ALS. The consequences of ALS diagnosis delay is missed opportunity to start disease-modifying therapy, missed opportunity to, enroll in early phase clinical trials, and impedance in referral to multidisciplinary clinics, which can improve patient outcome. here is like a sort of a timeline of evolution of electrodiagnostic criteria by the World Federation of Neurology. The criteria was first released in El Escorial, Spain in 1994. The first revision was done in at Early House, Virginia in 2000. And the second revision was done in Awaji Island, Japan in 2008. So let's talk about the, last revision of World Federation of Neurology for ALS electrodiagnostic criteria. The main utility of nerve conduction studies, as I have mentioned, is to roll out mimickers, especially that mimickers that are treatable, like MMN, multifocal motor, multifocal MMN, motor neuropathy with conduction block. So in ALS patient, we expect the distal latency to be normal or mildly delayed, the F-wave latency to be normal or mildly delayed, the proximal conduction velocity to be normal or mildly reduced, and we expect the CMAP depending on the severity of the the muscle tested. The severity of atrophy in the muscle we test. It can be normal, it can be reduced, or even absent. Uh, if we find like a demyelinating feature like markedly delayed distal latency, markedly reduced uh, proximal conduction velocity, uh, a conduction block, or temporal dispersion. All of these are features of a demyelinating process. This would argue against ALS and make us revisit our provisional diagnosis, unless we deal with like a focal process, like a delayed or a prolonged distal latency for the median nerve in the wrist, or a reduced, markedly reduced conduction velocity uh, across the elbow for the ulnar nerve, or a conduction block across the elbow for the ulnar nerve. These are focal, more entrapment mononeuropathy that can be, seen in patients with ALS. The main role for needle EMG is to show active denervations and chronic reinnervations. So the parameters for active denervations is positive sharp wave fibrillations, and newly added to this list is fasciculation in Awaji and revised Awaji criteria. So fasciculations has the same weight as the other denervation potentials, namely positive sharp wave and fibrillations. This point help in reducing the time to diagnosis of ALS, especially in patients in whom fibrillations and positive sharp waves are difficult to be seen. The other thing is chronic reinnervation. Chronic reinnervations, the parameters is here, as we can see early on. The early changes in volitional activation on needle EMG is only, reduced recruitment. As time pass on, there will be the living axons are sprouting to reach out to denervated muscles. This will lead to a remodeling of the motor unit. the motor unit, the duration of the motor unit will be increased, amplitude will be increased, and the phases of the motor unit will be increased. The other point in Awaji criteria uh, that have been emphasized in Awaji criteria, a new thing that both clinical and electrodiagnostic abnormality have an equal diagnostic significance. So the Awaji island criteria is resolved into a degree like of confidence. It can I mean the patient can be diagnosed as clinically definite, clinically probable, or clinically possible ALS, depending on the spread of, the disease spread into different body segments, the craniobulbar, cervical, thoracic, and lumbosacral segments, both the clinical and electrodiagnostic abnormalities. This, the criteria clinically definite, clinically probable, and possible, it doesn't mean that we are dealing with a different disease, but it's rather a degree of confidence in which each and every patient is allocated according to the clinical and electrodiagnostic findings. Back to our case. So, investigations have been done in an Al-Awtad hospital. The CT abdomen and chest was unrevealing. They were thinking of malignancy since the patient is a heavy smoker. Brain MRI, the report is unremarkable. Cervical spine MRI, mild degenerative disc disease. Thoracic spine MRI is unrevealing, and lumbar spine MRI is unrevealing. Here is our nerve conduction studies. Right median, right ulnar, right tibial, right peroneal, and the sensory potentials are all normal. There is no evidence of demyelinating features, no evidence of reduced CMAPs or SNAPs. EMG, as we can see, there is a florid denervation potentials, fibrillations, positive sharp waves, facets, and remodeling and chronic reinnervation in each and every segment of the body. Trapezius in the at the craniobulbar level, biceps brachii, triceps FDI, pronator teres, at the level of cervical level, thoracic paraspinal muscles at the level of the thoracic spine, vastus medialis, tibialis anterior, and gastrocnemius at the level of lumbosacral segment. So what are the lessons we have learned from this case? ALS is a clinical diagnosis. We could have diagnosed the patient with ALS on the clinical ground, and he would fall into a WASI clinically definite category. EMG and other investigations have served only to rule out mimics. EMG did not add much to what we already know from the clinical assessment. The time to diagnosis, remember the patient has, was seen already by 3 to 4 neurologists and 2 EMGers. The time to diagnosis from symptoms onset is still delayed, despite the fact the patient has been seen by 3 to 4 neurologists and 2 EMGers. The duration from symptoms onset to the diagnosis is 8 months. And the patient is in his way to seek another opinion in a tertiary care hospital. So what is the yield of Awaji criteria? Not much. The number of muscles with active denervation has been increased or have been increased by 10% only. The number of segments have been increased by 20%. So the role of Awaji criteria or the yield is not really much. Number of patients are moved, I mean, from the probable, from only 20% of patients have been moved from the probable category to definite category. Remember, all of these, all of two categories are eligible for trials. Questions unanswered. I mean, did Awaji criteria or has Awaji criteria help at all in upgrading patient in the possible category to probable category? It's unknown. Did it shorten the time to diagnosis? The question remains unanswered. So, what are the limitation in the current electrodiagnostic criteria? The nomenclature, like definite, probable, possible ALS, implies a level of diagnostic confidence, as I have said, that is confusing to patients, their families, and even clinicians, as all three levels diagnosis indicate an ambiguous ALS. PLS, based on the absence of lower motor neuron signs for at least 4 years after a disease onset, have a more protracted disease course and may never show the lower motor decline, and that which define ALS. So a patient with PLS will never be diagnosed as ALS and will not be eligible for clinical trials. This constitutes further barrier for patient enrollment in clinical trial. That is, a patient with a label of possible ALS may be denied entry to clinical trial, even though such patient might well benefit from the therapy at the earlier stages of ALS than those recruited late in the disease process. What about the other elements of other features of ALS, like frontotemporal lobe dementia, which is been well known features of some of the patients of ALS? What about the subdubulbar affects? They are not considered at all in the AWAJ criteria. Previous criteria are complicated to apply and are done so with poor reliability, even on the part of neuromuscular clinicians. So this has led the World Federation of Neurology to submit last September 2020 and come up with sort of new diagnostic criteria. The purpose of the new ALS simplified criteria is to improve diagnostic clarity and facilitate patient enrollment into clinical trials. The previous category of ALS diagnosis, clinically definite, probable, and possible, all of them have been dropped in the new simplified criteria. So, in this criteria, either it is ALS or not ALS. And look at the criteria; it's very simple. So, all what we need is a progressive motor impairment as documented by history or repeated clinical assessment, preceded by normal motor function. It is either presence of upper motor neuron and lower motor neuron in one body part, or lower motor neuron findings in two body parts. So it's very simple. And of course, we need to do our job in ruling out possible mimickers. So the take-home message is ALS is the most common motor neuron disease in adults. In the absence of biological markers, ALS is primary clinical diagnosis requiring the exclusion of alternative and potentially treatable diagnoses. The role of electrodiagnostic in ALS for the nerve conduction part is to rule out mimickers. For the needle EMG part is to show denervation and chronic reinnervation in clinically seemingly unaffected muscle. Given that ALS is a dire prognosis and there is lack of effective therapy, ruling out mimic, especially treatable ones, is as important as early diagnosis. We should avoid a premature closure and never completely close the door on a possible and alternative diagnosis. Thus, importance of like longitudinal evaluation of patients diagnosed with ALS by well-trained experts cannot be overemphasized. And with that, I will, conclude my presentation. Thank you.
Really, the ALS simplified diagnostic criteria made our life easier. Remember, with the ALS score reality criteria, we were very strict in diagnosing it. We knew that it's ALS, but it was not fulfilling the criteria. But now it's more simple, though ruling out other mimickers, of course. Thanks a lot, Dr. Mahmoud. We let the questions and answer till the end of the talk. Next talk would be done by Dr. Edward Koppler, who's a well-known neuromuscular specialist in the whole GCC and the subcontinent, American subcontinent, or the American continent. He's Dr. Koppler is a neurologist, consultant neurologist, and neuromuscular specialist. He's also deputy head of King Faisal Specialist Hospital and Research Center, and he's also director of neuromuscular clinic or neuromuscular service in King Faisal Hospital. His talk today will be on update treatment of ALS. Dr. Koppler, Dr. Edward, the floor is yours.
Thank you, Dr. Abubakar. I appreciate your invitation. It's extremely kind. And I'm going to thank Dr. Mahmoud for making my job easy. And let me just try to share my slides here. Updates in the treatment of ALS. It's a very troubling talk. For all of the neurologic diseases that we have conquered or at least started to address, ALS remains the poor boy out. And when Dr. Abubakar was making his comments, it immediately came to my mind that that's probably the reason why. It's very difficult to deal with a disease that we don't have a great treatment for, and I'll share that with you. I also do have two polls here to see what you all think and to keep you integrated. And also I'll share a video with you as well. So ALS is the current terminology, and I'll talk a little bit about the history, and let me just put on my laser pointer here. So these two guys here probably are the first in Western literature that described what we now call ALS. And actually ALS, it's not universal, not the universal name for the disease. We have a variety of names for it depending on where we live. This guy that I'm pointing out now on my left, I don't know which side is for you, is Professor Bell, who was Scottish. And we know him for Bell's palsy. Well, he was a very big neuroanatomist, though, and he talked about the differences between sensory and motor nerves, and he actually separated those two types of nerves. And in that, he identified what we now call as motor neuron disease in the UK, or ALS in Western countries, or if we're in a French-speaking country, we call it Charcot's disease, and this here is Charcot. So Charcot has really given us a lot as neurologists, and he is the first to clinically describe what we now call ALS. Actually, though, if we're coming from America, we really don't always call it ALS. We call it Lou Gehrig's disease, and I thought I'd share with you, if I can, this small video of Lou Gehrig. And it's probably my mistake. So basically what Lou Gehrig here is saying in 1939 is he's informing the world of his diagnosis of ALS and thanking them for their support and saying he feels like he's the luckiest man alive to have been able to do all he achieves, and he still has a lot to live for. Sadly, he died 2 years later. I'm sorry, the audio wasn't there, but I did make an error, I think, when I did my slide share. That's the same scenario I think that we have today. I don't think much has changed from 1939. He was diagnosed at Mayo Clinic. Here are people that either have had ALS or are currently battling ALS. We have physicists, actors, neurologists, Dr. Steve Olney from the University of California at San Francisco, who sadly died with ALS, soccer players, statesmen, musicians, and Olympians. ALS can affect any age group at any time, anywhere, although it's usually occurring in older people. Young people can be affected sadly as well. To bring it back to the foreground, we had this event occur, about 5 years ago, the Ice Bucket Challenge. And the Ice Bucket Challenge really went global, and everybody in every country, I think, on Earth participated to some extent in the Ice Bucket Challenge. And in USA, $220 million within a year was raised to help find a treatment or a cure for ALS. But we're not quite there yet. We're not even close. So I think we need to keep doing things to bring it to the foreground, to keep it in everybody's mind, so it puts pressure on the community to find a cure. We've all seen this atrophy and tongue fasciculations and atrophy in hands, and when you see this, you're just heartbroken. Until now, it's a very difficult diagnosis for me to make, and I do it very gently over a long period of time. It's not a first or second visit diagnosis to share, and certainly not a first or second visit prognosis to share, but it's important that the diagnosis is shared, and more important that the prognosis is shared. Even if the patient looks for an additional opinion, it starts settling in. And allows them to do the things they want to do in the time that they have left. The pathology of ALS, we've known this since Charcot's time, is motor neuron loss. This is anterior horn cell from lumbar spine, and what we can see is that this is on the top is normal lumbar spine, and this is in a patient who unfortunately died with ALS. And here we see motor neurons, and we see plenty of them, and here we really don't see many at all. And the same findings are occurring in the cortex. We know a lot more about this motor neuron loss than we did, but that has not translated into therapies, likely because the SOD1 mouse is the #1 animal model, and that only represents about perhaps 3 to 5% of patients with ALS. We're using the wrong model. The majority of patients with ALS are idiopathic, and we don't have a model for idiopathic ALS. We know more about it, and this was a big excitement when TDP-43 was found in these motor neurons of patients with ALS. And inclusions were also seen, and that was thought to perhaps lead to a potential therapy. And that may in the future, but it's not quite there yet. The genetics of ALS start with SOD1 in familial ALS, autosomal dominant, which is very old gene in the genetic world. This was described, I think, in about 1992 or 3, maybe a little bit later. And now we have many genes that have been identified, some of which are disease-causing, others are permissive. But the complexity is clear. The genetics are complex. And so this disease, I think, unlike other of our neurodegenerative disorders, is much more complicated than we initially thought out. Alzheimer's may equally be as well. It's a similar story. We don't have a great treatment or clearly no cure for that as well. Parkinson's, we have symptomatic therapy. And the reason I put those three together is we do have an understanding that there is a relationship between these three diseases, although that relationship is really yet to be clarified. So let's go on to treatment. This is a treatment, a treatment story. So let's talk about treatment. So let's talk about symptom management, because there we have effective therapies. Patients with ALS have a lot of symptoms, a lot of saliva, issues with saliva, and it's very embarrassing for patients. And you can use suction, you can use radiation therapy to the salivary glands, and that's still done. But most people nowadays would give Botox because that's effective, and you don't have other drug interactions or other issues with therapy. Low-dose amitriptyline is good, especially if patients have pseudobulbar affect, and low-dose amitriptyline will sort of address both of these very unfortunate manifestations of ALS. It improves quality of life, but it doesn't really improve quantity of life. But quality is important to this patient population, and they'll appreciate it. Some patients have very thick secretions, and this is a very concerning, because we always worry about patients dying from choking with ALS. And in my clinical experience, all of these things are mentioned. I think acetylcysteine, personally, that's a personal opinion, is really the best for this, and it helps people, get rid of those thickened secretions, and that improves their swallowing, and you can rest assured that they're not going to have choking episodes. Some patients have a lot of jaw clenching and spasticity in various ways, and you can do things to reduce spasticity. I have always been cautious about giving these type of medications to patients with ALS because it'll cause a little weakness, a little more weakness, I should say, and patients get very frustrated and think you're not helping them if you're giving a drug that makes them weaker. Botox, I think, is really the right way to go, and EMG guided Botox particularly to address the muscles that are really active during this jaw clenching. Spasticity, again, is another issue, and I already mentioned the risks of treating spasticity in people with ALS, and I have not done that with oral medications or baclofen pump for the same reasons that I mentioned earlier. If you give these centrally acting muscle relaxants, you're going to have a little additional weakness, and patients really don't appreciate that. A good number, like up to a third of these patients, have some sort of cognitive or behavioral impairment. It's unclear what to do about these things, but all sorts of things have been tried. It's important to look for them and identify them, and to ask about them, and then address them if appropriate. Asking people about their symptoms never hurts. It actually opens a dialogue, and they're very appreciative once you do. I should have said that about pseudobulbar symptoms as well. People will hate to tell you that they break out laughing or crying for no reason. You really have to ask them, and then you can treat those disabling symptoms effectively. Depression is real. It is usually transient during the acceptance of the diagnosis. Anxiety, it's the same thing, and having a good psychologist really is what is best, but medications can help dramatically as well. Weight loss is really the biggest threat here, secondary to respiratory insufficiency. These two are probably the most important two to monitor. And addressing both have probably done more to increase life expectancy of our unfortunate population than anything else that we've done. Patients that lose 10% of their body weight are at high risk. It's a very negative prognostic indicator. And so supplementary feeds, either orally or through an NG tube, G tube, or some way is helpful, or medications to stimulate appetite if patients will take them. But it is an important aspect is monitoring weight and weight loss and to intervene early. Also, with respiratory insufficiency, since the advent of non-invasive ventilation, BiPAP or whatever PAP that you're using, CPAP, BiPAP, this has really extended life expectancy for these patients, and it's been a pleasure to work for them. Sometimes it takes them a while to learn how to use the devices. SIP ventilation also is something that's good as long as the patient has adequate strength to hold the device, then they'll do that. Morphine is really a palliative component, and really in clinical practice, in outpatient clinical practice, there's no role for that in my opinion. So let's go talk about the drugs. It's therapies, so we'll talk about them. There are 2 medications approved that are supposedly disease-modifying medications. Both of them work in different ways. Both of them, in my opinion, are disappointing, and I'll share with you why I think that is. So the first and the oldest is riluzole. Riluzole is a glutamine antagonist. It inhibits glutamine release, and glutamine neurotoxicity is very important in the development of most neurodegenerative diseases and epilepsy as well, and it inhibits glutamine release, and it inactivates voltage-dependent sodium channels, and it interferes with intercellular events that are neurotoxic. So this was tried as a intervention for amyotrophic lateral sclerosis in the early 90s. And this paper was published in the New England Journal of Medicine in 1994. A controlled trial of riluzole and ALS, and it was by a French group. And I happened to be at the American Academy of Neurology when they presented the data, and it caused an uproar. People were really surprised with the findings, and there was a lot of discussion, and some of it was very heated. And this is why. So they did a double-blinded, randomized, placebo-controlled study, and what their outcome was death or a death equivalent, meaning intubation. And what they saw is that patients that were treated with 50 milligrams of riluzole twice daily lived a little longer than patients that received placebo. More interestingly, though, were patients with bulbar onset ALS did a little bit better than patients that had limb onset ALS, and this was very exciting. The whole, there was a lot of discussion about this because this was the first drug. Before that, everything had been tried in ALS and nothing worked. Everything from variety of antibiotics, total body irradiation, IVIG, plasmapheresis, all types of things, and nothing had shown this kind of difference. And this was seen. So this study happened to be conducted in France, and we're North Americans, so there was that cross-Atlantic dialogue that happened. And a second, third, and fourth study were done, and all showed about the same results, where riluzole had a little but real difference in extending life. And Bob Miller in San Francisco did a Cochrane review. Oh, I don't know. I think this is in 2018 or 12, and said riluzole. The bottom line is riluzole 100 milligrams daily is safe and probably prolongs survival by about 2 to 3 months in patients with ALS. Back in 1994-5, we thought that was the start, and then that people would build on that particular drug, but unfortunately, we didn't see that. What we saw was a void, and nobody liked that void. But that happened. So riluzole here, how it's prescribed till today is 50 milligrams twice daily on an empty stomach. For whatever reason, charcoal foods that are barbecued will inhibit its uptake and metabolism. People usually tolerate it well. A few people will have elevated liver enzymes, but not much. It causes a little bit of nausea or abdominal pain, a little bit of fatigue, but those usually are transient. Serum ALT levels should be checked monthly for the first 3 months, and then every 3 months for the first year, and then occasionally thereafter. And the current cost for that is about 54,000 Saudi riyals a year, which is maybe a little bit more, I think, in dirham. So it's an expensive drug, maybe. It might improve longevity a little. There's no real meaningful side effects, but patients will not improve. So it's important before you start a drug is to establish expectations. So this is the first poll. Now you have a patient you've diagnosed with ALS, and you're going to start them on riluzole. And you're having that discussion, and they're asking you, what should I expect? What are you going to tell them here? I don't know who's going to run this. Am I going to launch this poll? Okay, you're going to have 20 seconds or so, so please vote on the poll there, if you know how to vote. I don't know how to tell you to vote. And I think I know how to share the results. I see there's a lot of people here. Please, I'm going to relaunch this polling because only 3 or 4 people answered. So let's relaunch it. Can we relaunch this poll, please? And get a few more people to answer? I see you out there.
We have 680 participants.
Okay, well, the first time around we had 3 that answered.
Oh, that's amazing. Out of 683.
Yeah, well, we're doing better now. We have 40 or so.
Okay.
Okay, hello. Bring it to the front. Okay, let's share these results. I don't know if I'm doing it. I don't know if anybody could see it. Attendees are now viewing the poll results, so I think you can. Well, the majority of you said stabilization, but no improvement. This is not the correct answer. When you give a patient really, and some say mild improvement, and some say recovery, and I think that guy's just, or gal is just trying to wake me up here to make sure that I'm paying attention. When you give riluzole, you should tell that patient they are not going to notice any difference, and they will continue to worsen. It might be at a slower rate. And then they'll believe you. They won't come back in 3 months and say, doctor, you gave me that medicine and it doesn't do anything. We wish it would stabilize patients. If we could stabilize patients with ALS, it would be heroic. Sadly, we can't do that with this drug. So patients should understand they're going to continue to worsen, but it's at a slower rate perhaps, and it'll increase their life expectancy if you're at that point of having that discussion for a while. So that's that. So let me stop sharing. And we'll go forward again. So let me see if I can go forward. Oh, I cannot move this. What shall I do?
Click the screen and then move your mouse. Move the video.
What shall I do? Okay, good. Oops. Okay, it worked now. So then we have the second drug, Neuron. Neuron has a long history as well. Neuron is a Japanese drug. It is a free radical scavenger, and it was developed in the late 80s as a treatment for stroke in Japan, a stroke treatment. It was approved for stroke in Japan in 2001, and somewhere around that time, or maybe a little bit later, they started looking at it in ALS because there was a lot of discussion about free radical toxicity in ALS. And so they thought, well, there's a role for this in stroke in Japan. So why don't we look at ALS? So they did it, and it was approved in 2015 for ALS in Japan. It's really not clear what the mechanism is exerted in ALS, but we'll go through the data here, and we'll talk a little bit about the cost. This drug has a little bit of a controversy about it because the cost in Japan is dramatically lower than it is anywhere else in the world, and people are concerned about that. So in all the trials nowadays, the ones that I'm going to talk, the primary outcome is a comparison in the change between the treatment arm in the ALS FRS revised, which is the ALS functional rating scale score. So it's really a score that is generated, and then what's looked at is there a change in the score, or is that from either baseline to follow-up, or between treatment arms, or against placebo. This is the primary outcome for everything. And what you can see here is a very gross scale, meaning there's a lot of difference between the numbers. It's definitely not linear. And we need to understand that, because linear scales are really good for statistics. Nonlinear scales are very complicated to do statistics on. And there's definitely not a single unit between the two numbers in any of the components. So patients who are on ALS studies now, especially with this drug that we're talking about, were all looked at based on the change in the score, and a 2-point change was considered meaningful. So the first study, which was done in 2006, was a great study. It was open label, proof of principle, does anything happen? And it was a small study, 25 patients, and likely it was small because they had two endpoints that they were looking at. One was the change in the ALS functional related score, revised score, and the second was looking at CSS levels of 3-nitrotyrosine. And so you can't do lots of spinal taps on patients. So you look at baseline and follow-up. And what they wanted to see is proof of principle. Was there any difference? So they enrolled 20 subjects. And really the analysis was really done on the higher dose subjects. So the dosing is very complicated for this drug. It's given 60 milligrams IV daily for 14 days. Then you let the patient rest for 2 weeks, and then you repeat that. So basically, for 2 weeks a month, the patient is getting an IV medication. And they did that for 6 months. So what they saw is a change, and they took baseline scores of this ALS-FRS, and they saw that there was less decline in the 6 months on treatment compared to the previous 6 months when the patient was not on treatment. Although the CSF 3-nitrotyrosine was a secondary endpoint, it was more exciting because it was reduced to undetectable levels after 6 months of therapy. And so people were really excited that they had something here. But interestingly, it took a long time to do what they called the confirmatory study. So I think I deleted a slide here. Yeah, unfortunately. So I'll just share it with you though. So they did a confirmatory study, which was a great randomized placebo-controlled study looking at a big group of patients, 206 patients. 104 patients were randomized to drug, 102 to drug, 104 to placebo. And again, they were treated in that same fashion for 6 months, and they looked at outcomes. And surprisingly and sadly, there was no difference between people who were treated versus people who were not treated with Neuron. So that was published, and there was a lot of discussion about that, especially because of the preliminary trial. And so they did a post hoc analysis. And what they thought was that patients who were treated earlier on in their disease course, meaning people that were treated at less than 2 years of symptom onset, did better than those who were treated later. So a third study was done looking at that patient population. So it was a 6-month, again, randomized placebo-controlled study, double-blinded, with 137 Japanese patients. And this is a critical statement, who were living independently. They were able to do most of their activities of daily living. They had normal respiratory function. They had definite or probable ALS based on the Ezekoriel criteria that Dr. Mahmoud had shared with you. And the disease duration was 2 years or less. So this study was positive. And what we saw was a slowing of progression in patients who received what we call now Radicava or Neuron compared to those who were on placebo. So both groups declined, but the patients declined at different rates. And we look at this scatter plot here, and you can see that most of the patients did worse with time. There was a single patient in the study who seemed to do a little better or was stabilized, but all of the other patients who were on treatment did deteriorate with time, but at a slower rate than those in placebo. So with this study, the US FDA approved Neuron or Radicava, I think I spelled that wrong, in 2017. It is a very complicated drug to give. It's given IV over 60 minutes, 60 milligrams. Although you can't put the whole 60 milligrams in the same bag, you have to divide it into two bags, and then you infuse it. Your loading dose is daily for 14 days, followed by 14 days off. And then subsequently, you're giving 10 days on out of 2 weeks, followed by 14 days off. That translates into 124 infusion days per year, or about a third of the year the patient is attached to an IV, an IV, either in your, wherever it is you're giving people IV medications. Also, this drug has hypersensitivity reactions. It contains a sulfite, and patients can have anaphylactic reactions or severe asthmatic episodes. Usually that'll occur within the first first set of infusions, and then you have to decide what you're going to do for it. But this is the surprise is the cost of this drug is about 540,000 Saudi riyals per year plus your infusion costs. In USA, that translates to over $146,000 plus $1,000 per infusion. So I don't know about that. So there has been a meta-analysis done looking at all three studies. There's been a total of 368 ALS patients that have been studied using drug or placebo. The side effects probably are not, they think is not statistically significant. Mortality does not differ between those groups, and I think that's very important to understand. The mortality is not different between placebo or edaravone, although the patients don't deteriorate as quickly as those that are treated. But they both groups deteriorate. So now we have the second question here, second poll. So now you're talking about a patient who you're asking to spend 124 days a year in a treatment center to get this IV drug. He's going to ask you, doctor, what should I expect from this drug? So if you can open that poll, please. Okay, the poll is open. What do we have? Again. Okay, can you relaunch that poll again? So maybe leave it a little longer. It's only 4 people answered. Okay, I think we can end the polling now. We have about 100 answers here. Thank you for answering. So let me share the results here, or somebody's sharing them for me, that's better. So mild improvement. No study has shown that. What the studies have shown is people treated with edaravone, like riluzole, continue to worsen. And that's important for the patient to understand because they're going through all this effort of coming to that clinic to get that infusion. They continue to worsen. 7 people said recovery. God bless you. I wish you were my doctor. If I had ALS, I'd come to you. There hasn't been any ALS patient that's been treated with this drug or any drug that I know of that indeed had ALS that is recovered. Even with paraneoplastic ALS, which hasn't been really discussed, it's something we always look for. The best that we see in paraneoplastic ALS is stabilization, or maybe a little bit of improvement. They don't go back to normal after the cancer is treated. So the drugs really don't do that. So if we can stop sharing the results, and I want to move on. Can I move on? What do I do to move on?
Click on your presentation again, and then.
Oh, okay, thank you. So I think this slide can explain why one drug does not fit all. So these are all the different activities that have been described in the last 30 years that is going on both intra and extracellularly in patients with ALS. We have numerous derangements, numerous cytotoxic events, not only excitotoxicity with glutamate, and not only excessive oxygen radicals. We have many other things going on. And what we're seeing here is where both riluzole and edaravone act. Green is edaravone, red is riluzole. So to think we can interfere with this process with a single medication and expect stabilization or recovery, I think is not intuitive. You know, one drug fits all is really gone, and this is why we have personalized medicine going on nowadays. And what we need to do is advocate for a personalized approach to ALS, but we're not there yet. So if we look at these two drugs side by side, the mechanism of actions, glutamate antagonist, free radical scavenger, riluzole is oral, and edaravone is IV. The effects that are shown in studies, which are important, because why is it important? Because you know that patient had ALS, and patients in studies pretty much had ALS. Patients in clinical practice that are treated with something may or may not have what we think they have. So riluzole may increase life expectancy by 2 to 3 months. And edaravone decreases the rate of symptomatic progression, but has no effect on life expectancy, at least as we know right today. The FDA approved this drug in 1995. 22 years later, the second drug was approved. That should tell you something. This disease is very complicated. The cost per year, this is in US dollars, for riluzole is about $14,000. For edaravone, it's a tenfold increase, $146,000 plus infusion cost. And for this drug, a patient is spending about a third of the year having his treatment with a life expectancy, of less than 5 years. So a third of his time is attached to the IV infusion pump. People with ALS can be helped, but I think we have to get over the idea that we're going to help them with the medication. We need to get our team around them, and we have the physical therapist, the occupational therapist, critically the respiratory people, the speech pathologist to improve swallowing, to improve nutrition with the dietitian. Getting these patients involved with studies, which means the onus is on us is to get clinical trials happening in our centers to give patients something better than we can give them right now. So and as well as the caregivers, the family and friends, and I think these are the biggest important people to support in addition to the patient with ALS. We can't rely on a drug. The drugs really haven't gotten there yet. We're hopeful. And why are we hopeful? And I think this is my next to the last slide, is what's going on. And I did this, I think, yesterday just to see on trials that are recruiting in ALS, this is globally on clinicaltrials.gov, there are 138 studies that are either not recruiting or recruiting for ALS. And we also searched for motor neuron disease and Lou Gehrig's disease. I showed you Lou Gehrig earlier. I apologize that I didn't put the sound on again. And we can see about 138 studies are ongoing. About a third of those are medications, and I think two of them are stem cells that are neuronal stem cell transplants that are going on. So that's the future. So I think we have to be realistic when we're dealing with patients. We have to be honest and do our best with the things that we can interfere with, and understand what our limitations are and things we can't, and not provide false hope, especially at with the medications that are currently available. So that's all I have to share with you. This is again Lou Gehrig. This is his baseball that he gave the Mayo Clinic. He was diagnosed at Mayo Clinic, and this baseball is part of their collection from 1939. And that's all I have to say. Thank you so much for listening and taking the polls. And thank you for including me in this very nice, important conference.
Thanks, Dr. Kupler, Dr. Edward, for your nice, excellent talk as usual. Unfortunately, we have a vaccination for COVID, but we don't have nice treatment for ALS, despite spending so much research on it. It's an unfortunate if someone has ALS, but the good thing about it, people don't die suddenly. It's a progressive disease. It's a painless disease, as we know. So we move to questions and answers. Dr. Mahmoud, if you're available, you can open your chat.
So the first question is from Rabha Al-Sahli. If a patient has a clinical picture suggestive of ALS, on top of it has previous cervical problem. Now, how can we diagnose ALS from electrodiagnostic point of view? So basically, ALS is a clinical diagnosis. It is mostly painless, pure motor neuropathy. While on the other hand, like cervical spondylosis is painful, and there is like a prominent sensory component of the condition. We should, examine the patient thoroughly in each and every segment. So if the patient, for example, has like bulbar symptoms in forms of dysarthria or dysphagia, and there are signs of tongue atrophy and fasciculations and fasciculation beyond the upper extremity, like in the thoracic segment or in the lower extremities. These are all suggestive of ALS, and this is not like a confined focal process, and it is suggestive of a more generalized process like ALS. It's not uncommon for patients with ALS to have some disc here and there, but if there is like a diffuse, painless, pure motor process, this will make us lean toward an ALS.
Unfortunately, I don't have the questions and answers.
How does riluzole affect the brain? Riluzole inhibits glutamate release, and glutamate we know is neurotoxic. That is the mechanism of action, and it does that centrally. So it's a centrally acting glutamate antagonist, and that's how it would affect the brain. Thank you.
The third question is from an anonymous attendee. Which MND is difficult to diagnose? I mean, with more mimics. Is it upper motor neuron or lower motor neuron disease? Well, I have, I cannot answer this question. I think it is a case by case. Some cases are difficult. Some patients are easy to diagnose. So it's a case by case. I cannot answer this question from my point of view.
I can ask one question to Dr. Edward Coupler. There is a new drug which came in the market. It's in phase 3. It's called masitinib.
Yes.
Any experience about it, or do you know?
Well, I've read about it. It does look promising, but everything has looked promising. So it's better to wait until this phase 3 trial is really completed. The phase 2 results were exciting. The phase 3, we have to wait and see what's reported.
Having said that, in edaravone, in few patients that had been given, I found some improvement, initial improvement in ALS functional score. Then they start to plateau. Yeah. Have you noticed this?
Yeah, I have treated a few patients, I'll say that, at their request. And what I've seen is in the first loading dose, like after the loading dose, you might see a little improvement, but by 6 months that really has gone. and they continue back down on their downward progressive journey. I haven't seen anything last 6 months in the few patients that I've personally treated.
Exactly. You can keep on, Dr. Mahmoud.
So I mean
We have 4 more minutes.
the other question is, what is the genetical significance in ALS? So ALS can be familial in around 10% of the patients. And if so, what can be done at the earliest? Well, a genetic study can be helpful, but there is like a poor genotypic phenotypic correlation and the penetrance in AL, I mean, in the from the genetic point of view. So genetic counseling can be important, but there should be like a full disclosure about this poor correlation.
Dr. Edward, you can pick the next question.
Yeah, it's also a genetic question, and you know, the genetics of ALS were really began with superoxide dismutase mutations, and that's why the whole interest in free radical scavengers came about. So the first autosomal dominant ALS was found to be a mutation, 2 mutations or homozygous mutation in superoxide dismutase. It's it's a heterozygous mutation because it's autosomal dominantly inherited. That has been a fortune to diagnose that or understand that, but then it's been a misfortune because the SOD1 mouse became the model for ALS, and I think that's why we don't have any, any real treatments because everything is done on that mouse model. So it is genetically acquired in a small number of patients, up to 10% perhaps, if you include permissive genes. It does have a genetic component to it.
I have one question for Dr. Cobbler, if you don't mind.
Go ahead.
I mean, do you believe in ALS reversal?
In ALS reversal?
Yes.
Well,
Have you
believe
seen?
I haven't seen. The best that I've seen in my experience has been in perineoplastic ALS, meaning a patient has some cancer. I've seen maybe 4 in my career, which spans a lot of years, that have been diagnosed with some sort of a tumor, and then when when the tumor or the cancer is removed, then the patient stabilizes. I haven't seen improvement, meaningful improvement, or persistent improvement in a sporadic ALS patient. And in SOD1, and I have seen a good number of SOD1 patients in my career. They're uniformly very fast progressive disease, and I haven't seen any of those people do well.
Thank you very much, Dr. Mahmoud. Thanks, Dr. Edward. We hereby conclude the talk. It's a very nice talk. We made an achievement in ALS world by making the diagnosis more simpler. There is one new treatment which is ongoing and one new treatment which is probably coming and it's promising. They used to say it's a nice people's disease.
Yes.
I'm not sure how accurate it is, but I've seen this and experienced this, and most of those people are nice people.
Yes.
So that tells us not to be a nice person, so you don't get the ALS. Okay, so we almost reached 680 participants, so that's a big and huge number, and it means how interesting people are. And thanks all for attending this session. And thank you again, Dr. Mahmoud and Dr. Koppler, for attending
Anytime.
and holding this talk. Thanks, and we meet
Thank
next.
you, Doctor. Thank you so much for inviting me.
Thanks. Shukran.
Thank you. Have a good night. Thank you.
Thanks.
Thank you, doctor.